Good morning, everyone. Thanks for coming out. What another gorgeous morning we have here. Absolutely perfect. First of all, can we all acknowledge that the rest of the panel realized there was a uniform for this panel and I did not? I mean, that's pretty great. I'm David Leonhardt, ill-dressed David Leonhardt. I'm an op-ed columnist at the New York Times. I've seen many of you here over the years. My background is more in economics and politics, but around about 2006 or 2007, I really started diving into healthcare, in part out of the expectation that there would be a big policy push, which of course there was. And I spent a lot of time visiting hospitals and talking to doctors and policy experts. And more recently, I've spent a bunch of time on public health issues like diet and driving, the fact that the United States has the worst traffic fatality rate of any rich country in the world. So I'm not a healthcare expert like these folks, but I'm really excited to be up on stage with them. And what I'm going to ask each of them to do, starting with Toyin on the end, then we'll go to Jay and to Keller, is to briefly introduce themselves so you get a sense of their background. And then we're going to dive into a conversation. We're going to talk about healthcare and health in the United States. Then we're going to expand it to talk about health and healthcare in the world. And then we're going to open it up to you all and get your questions and thoughts and comments. So with that, Toyin?
Sure, thank you so much. I'm really thrilled to be here. It's lovely to see you all this morning. My name is Toyin Ajayi. I'm a primary care physician. I'm also the co-founder and chief health officer of a New York-based startup called City Block Health. We're focused on providing integrated primary care, mental health, substance use disorder treatment, and social service coordination for underserved communities, specifically focusing on people who are recipients of Medicaid or dually eligible for Medicare and Medicaid. This focus for me is sort of it's a lifelong passion in really thinking about how we transform our delivery system to better meet the needs of folks who have deep and multifactorial drivers of poor health and poor outcomes. Part of what's interesting about the world we're in today is that our company, City Block Health, was incubated at Sidewalk Labs, which is an alphabet company. And that allows us to really bring together technology, new technologies, new innovations, as we think about ultimately a very human-centered, person-centered, community-oriented care model. So I'm excited to be here and looking forward to talking with you.
Thank you.
Hey everyone, I'm Jay Komarneni. I don't know if that's on.
Yeah.
Hey everyone, I'm Jay Komarneni from the Human Diagnosis Project. Our goal is to help build an open medical intelligence system that maps the steps to help any patient. We see this as a natural continuation of the ideas of the Human Genome Project. As opposed to just encoding the genetic code, we actually need to encode all of the information which ultimately impacts our health. Symptoms, lab test results, physical exam results, genomics, proteomics, the microbiome, all of that needs to exist in a single open place that can be accessed by anyone, anywhere, to ultimately solve the essential question of human health, which is when someone you love isn't well, what should you do?
Hey everyone, my name is Keller. I'm the founder of a company called Zipline, and we build instant delivery for medicine. So today in Rwanda, we deliver about 25% of the national blood supply of the country using autonomous aircraft. So these are like 20-pound airplanes that run on batteries, and we're able to deliver blood to hospitals across the country so quickly that patients don't know it's not actually stocked at the hospital itself. Wow. And centralizing inventory in a healthcare system typically allows us to dramatically reduce waste while increasing access and then bringing medical care closer to where people live, which is generally the goal of our company.
Excellent. Thank you all. So as I mentioned, we're going to start with the US, spend a few minutes on that, and then go to the world. So there was recently a piece in the New York Times by Austin Fracht, who's an economist at Boston University, which noted that until about 1980 or so, the United States looked normal in terms of both health outcomes and health costs for a rich country. And since 1980, we've stopped looking normal in the worst of all possible ways, right? Our costs are higher, our outcomes are lower. And so I guess the thing I wanted to ask you all, and Toyin, I'll start with you, what role do you think technology can best play to try to push against this worst of all worlds situation we have for a large portion of the population? High costs, poor results.
Yeah, wow, huge question.
Huge question.
And I'll take a stab at it. I mean, I think, as you all know, once you start to disaggregate that top line kind of headline, what we see is that it's not universally that we spend a lot. In fact, we spend a lot in probably the wrong places for the wrong people at the wrong times. And when you get to the segment of the population that I'm particularly interested in focusing on and in really improving outcomes for, what we find is that we spend a lot of money in reactive, low-value care, emergency rooms, hospital stays, readmissions, procedures that don't necessarily derive value globally to that person and to their well-being. And we spend very little on community-based supports, on primary care, on social services, on housing, on food, on transportation. And so one question here is, as we think about the sort of trajectory of technology so far in healthcare, recognizing that, to your point, we haven't actually been focused on this question, on how do we ensure that we are applying technology in ways that do not continue to reinforce what we're seeing in this pattern of high cost and poor outcomes. And unfortunately, to date, much of the technology that we have seen has been exactly along those lines. It's been transactional. It's been about trying to provide solutions to people, frequently folks with the means to pay, that effectively translate into more utilization of certainly different types of services, but not that address the underlying fundamental question of, to some of the work that Jay's looking at, what is the right intervention for this person at this time for the needs that they have? And more often than not, when we start to ask that question, we start to really focus on very different areas, very different levers, things like community-based supports and primary care and outpatient mental health. Where I think technology can be really interesting is starting to help us answer that question at the point of contact, almost at the bedside, to help us start to disaggregate all of the noise around healthcare and really focus on what the right interventions are for that right person. When I think about myself as a physician, for example, in clinical practice, the sum total of what I know is, the patients I've seen in my experience, and the papers I've read, and the sort of accumulated knowledge of others. But we know that technology and big data can help us democratize huge amounts of knowledge that allow me as a clinician on the front lines to be much more targeted in the way that I deliver care to patients. So I think that's one area particularly where I'd love us to sort of dig in a little bit more, to think about how we can apply data to not just the question of can I fulfill a mandate of more healthcare for any person who wants to pay, but can I fulfill a mandate that is much broader and much more societal and much more aggregated?
You want to jump in?
Yeah, absolutely. So I think there's a couple areas that we see the future of healthcare delivery going. So the first is one that is highly distributed. So through the combination of technologies like Keller's, the ability to do things virtually, the ability to have delivery services, all of these will push care to the edge into more distributed settings. So that includes home care, that includes telemedicine visits, it includes all of the opportunities to have care outside of the traditional care setting. So that's one area that technology can play a big role. The second area that it can play a big role is in coordination. So as you know, many medical errors, many costs in the healthcare system result from administrative problems as well as handoff problems. And the ability to use technology to more seamlessly orient that as well as ensure that it happens in a very careful and thoughtful way is kind of the second area that we think technology has a big opportunity to impact this problem. And then the third area is really around measurability and value-based care. And so today, the ability to do value-based care is still unscalable. So if we look at risk-based models, they're fantastic and they work extremely effectively. But the problem is that they require individual bartering between healthcare institutions and payers. And in the future, we need to kind of move towards a model where we have independent assessments of value so that we can actually move, even in a fee-for-service world, towards a system which can be value-based. And then I'll add a fourth one, which is we really view that in the future, care will be much more collective. So that doesn't just include the patient and their loved ones and other participants in that process, the community, et cetera. It also includes using more healthcare workers to provide disparate perspectives on the same problem, because in our internal research, the combination of individual physicians with machine intelligence can outperform 95+% of individual physicians.
How do we deal with?
Can I make a really quick observation?
Yeah.
So as someone who's trying to make advanced technology work for the healthcare system, one thing that I've noticed talking to people here is that doctors hate technology. So can we just address the elephant in the room,
Yes,
which is
please.
that people are so pissed off at the EHR system in the US, and most technology being brought into a doctor's life is not helping them, but actually hurting them. And I think the big differentiating factor there is actually when you have a market that's so regulated that the only technology companies that can play are Oracle and IBM, this is not the best that technology has to offer. And actually, I think in some ways, because we get to operate in other countries where it's more possible for technology startups to actually operate and provide services, that's where you actually see technology really solving problems in efficient, user-friendly ways. And in some ways, I hope that we can actually take some of those learnings back to the US healthcare market over time, where it can become possible to try new things and for technology startups to actually serve doctors.
What's a
rather than
good
just
example of how in another place where you're not hampered by so much regulation, you're able to do something that really works?
I mean, I think a really nice example are these ultrasonic monitors that GE makes in Africa, right? Like they design them at really low cost, and they can be used at a much different level of healthcare than traditionally you'd see in the United States, and they did it for 1/100th of the cost of what's available here.
And why can't we do that here?
You know, I think people in this room would know better than I would, so I wouldn't
Yeah.
really propose to be an expert, but I think that every regulation is created by someone with a good intention, but the sum total of regulation often makes it impossible for anybody but the richest technology companies to play.
I actually have a worry that's even sort of bigger than regulation, which is if you look across fields, everything we know about psychology and behavioral economics and all this research is that human beings are terrible at knowing our own weaknesses, right? And so you mentioned that technology and algorithms are often better in 95% of settings.
No, that's actually the intersection of humans with algorithms.
The interception of humans with algorithms.
Exactly.
But even so, when an algorithm makes any kind of little error, right, we tend to overweight. We say, oh my goodness, right? We see this with driverless cars now, right? We sort of overweight it. How can we overcome, obviously technology has limitations and weaknesses, but how can we overcome our deep-seated human overconfidence to really get the best out of technology?
If I could maybe take a step. So prior to a year ago, I'd met, but I'd never actually worked with a software engineer. I'd never had anything to do with technology besides, to your point, hating it as a doc with an EMR all day, every day. You grow to like deeply, deeply hate your
And just to be clear, EMRs and EHRs are the same thing,
Same
right?
thing, yeah.
Electronic medical records,
electronic
electronic health records.
Right.
Sorry to interrupt.
Yeah, sorry about that, sorry. And so over the past year, I've had the experience of building technology specifically geared to helping us understand what's going on with our patients, helping us drive decision support that's meaningful and relevant to that individual person, that takes advantage of our kind of collective knowledge about what works for people, helping us prioritize with patients, helping us be accountable, so just tracking what we do and making sure we close the loop, and then helping us build partnerships with community-based organizations that very frequently are still operating on Excel spreadsheets and pen and paper. And that process actually for me has been really, really illustrative about how we can break down that mistrust and that antipathy that physicians tend to have with technology. And it's not just about regulations, and it's not just about the fallibility of technology. I think there are really simple things we can do about bringing the end users into the process of design, and then making sure that whatever outputs we spit out are explainable. And so, as we started to bump into starting to do some work with machine learning, as many of you know, the connections that you're able to put together using artificial intelligence often aren't sort of explainable in easy language to end users. And so there's a process there of figuring out how you just render to a person that says, it's not a driverless car, it's a GPS, right? It's saying, I think you should go left here, here's why. If you choose not to go left, that's fine, we're gonna keep track of it, and maybe we'll feed back to you over time. We need that. We don't need a driverless car yet, because to your point, we don't trust it yet. And frankly, I think there's a lot that we don't know where we want to ensure that we have that sort of ultimate ability for that human interaction to override.
Yeah. Jay, you mentioned something before that I wanted to come back to before we fully go global, which is there's been this debate in the past, does the US have an overtreatment problem or not? Right? The late Uwe Reinhardt, one of the great health economists, essentially argued no. He has a famous medical journal article titled, It's the Price is Stupid, right? And so his argument is no, actually the problem is not that we do too much in the United States. The problem is that we pay everyone too much. We pay doctors too much. I realize doctors would disagree. We pay hospitals too much. We pay pharmaceutical companies too much. I know they would disagree. We basically pay everybody too much, right? Others have said, no, yeah, that exists, but we also have a problem of overtreatment. Given the work that you do, which is obviously very much around diagnosis and understanding, what's your view of this question of whether we have an overtreatment problem?
It's actually much of both. So I think the interesting thing about what Keller said is all of these problems are interdependent. So as an example, the reason doctors are so frustrated and burnt out in terms of all of their documentation requirements is because of the code-based fee-for-service world that we live in. If you're always trying to move towards a code and you have to use these EHRs that are extremely painful to do so over and over, you're not going to enjoy clinical practice. And really the opportunity for technology is to actually modify and improve that. So one of the things that we're trying to do is helping to automate the clinical documentation process, as well as things like CME, MOC, peer review, and other requirements. Now, to your question about...
That's continuing medical education.
Oh, sorry, excuse me. Continuing medical education, maintenance of certification, peer review, these are all kind of requirements that all doctors are required to do. And it creates a lot of time sink and effort for them that they don't otherwise need to do. Now, that problem is also connected to the fact that health systems, because they're highly regulated, are very difficult to start in any given region. So they create regional monopolies that ultimately drive up prices. And so those problems are interconnected. Then the problem on the payer side is that because we have medical loss ratio and it's capped in terms of how much you can make in terms of profit, there is actually no incentive to reduce costs because you're making your profit on a higher cost basis. Yep. So if you have a capped margin, that's just essentially the way the evolution of the market will happen. So all of those three kind of problems are deeply connected. All of that aside, we still have a problem of medical errors, misdiagnosis. Medical errors, as you know, is the third leading killer after heart disease and cancer in this country. And a lot of those are kind of more traditional operational errors, but a lot of those are actually medical errors of diagnosis, of treatment, et cetera. But the bigger reason that's a problem is because in a fee-for-service world, there's a tremendous incentive to just do as much care as possible with respect to these health settings, as opposed to do the appropriate amount of care. And on the other side, the payers have an incentive to reject potential care. So basically the patient is caught in the middle, but there's no third party to really kind of say, hey, this is actually something that seems reasonable, or this is something that seems high quality given the context.
Yeah, makes sense. So when we were talking before, we were talking about the ways in which the problems in the US are different from the rest of the world and similar, right? And on some level, it seems, and I want to ask all of you to weigh in on this, starting with Toyin. On some level, it seems as if, boy, they're so different, right? We spend too much money on health and healthcare in this country, or at least on healthcare. That's not a problem in the rest of the world. How do you see the similarities and differences between the United States problem and the problem in the majority of the world?
Sure, yeah. So I think there's a lot we can learn from the global south, if you will, from non-developed countries. And I think that there's a lot that hopefully we can help them bypass as we sort of move towards leapfrogging in technology in particular. And so, I spent my childhood in sub-Saharan Africa. I worked in global health prior to finding myself really focused on underserved communities in the United States. And so those parallels are really evident. We continue to have a challenge around within a limited resource base. As we talked about, we spend a lot of money globally, but we really underinvest in a host of very key areas for underserved communities, particularly in social services, particularly in primary care and mental health. We have a challenge around access for folks in rural areas in particular, access for folks who don't have transportation readily available. We have a challenge around trust building. We certainly have a workforce challenge here in the United States, particularly in our underserved communities. Not enough primary care providers, certainly not well-leveraged community-based non-clinical providers. We think about community health workers, et cetera. And so I think there's a lot to learn here, and it's particularly exciting to see technology like drones for delivery of supplies in hospitals being used in a place in a setting that we haven't seen in the United States. And so much for us to learn, having kind of leapfrogged in many ways the operational and logistical challenges that we're continuing to be mired in here. So I think there's a lot to learn both ways, and it's pretty exciting to have an opportunity to sort of start to bounce those ideas across fora.
Keller, how do you think about it?
Yeah, I think, well, obviously what's exciting to us is that I think people have this paradigm that all advanced technology will start in the US and then trickle down to the rest of the world.
Yeah.
Right.
And that is like really not the case anymore. When we talk about what we do, most people in the US still think that that's technologically impossible. And yet there are like doctors across the country of Rwanda who are like, yeah, of course we have a drone that delivers the blood.
What else would
How else would you solve that problem, idiot? So I think, in some ways as a US citizen, I see that and it's a little depressing.
Yeah.
Because it's like we're falling behind every day. But in other ways, I think it's incredibly inspiring that it's actually not about the country that has like the most resources or the biggest base that can actually innovate. It's actually now up to, I think, some of these smaller moving countries with more functional governments and aligned incentives in the medicine system to actually save money or provide better care to patients. So I think those are all three big things that typically maybe have been our advantage but are becoming our disadvantage. And as you said, at least my hope is the same, which is that the U.S. can now be a fast follower and can learn from a lot of these countries that that are innovating.
Yeah, one other thing.
Jay.
Oh, sorry. One other thing is, I mean, when we think about the rest of the world, the most recent World Bank report said 3.5 billion people lack access to essential health services. So I think that's really important to remember that we're talking about a system where there is no system. There's nothing there, right? And so when we think about how are we going to solve that, some of the points I mentioned earlier are really key. So one is kind of the point about being highly distributed. So the value of having the ability to transfer products quickly through things like drones. Another example is we have to be able to deal with offline and low internet settings through things like mesh networking. Edge computing is another thing that's really important because a lot of times if you're going to take advantage of algorithms and you don't have reliable access to the internet, you need to make decisions quickly. You can't do that unless you can compute in a local way, not just a global way by hitting a server, right? So I think that's kind of 2 points that are really important, but really the only way we're going to actually get to universal care or care for all is if we can up-level or upskill people who have certain skills to do more than they were otherwise capable of. So we have to give the primary care physician some of the abilities of a specialist, and that's kind of what an e-consult does. We have to give the nurse some of the abilities of the primary care physician, the community health worker some of the capabilities of a nurse, the patient some of the capabilities of a community health worker, and by shifting that stack down, that's how we can actually move towards universal care.
You were going to say
Yeah, and I would add to that. I mean, I think we have a sort of a moral and developmental imperative to start there because we know that if we continue to build technology for those who have means, for those who can advocate for it, for those who can access it readily, that doesn't trickle down to the populations who really need it. And the idea of building intentionally for underserved communities and individuals, building intentionally for low internet access, for low literacy, for poor road networks, for people who have competing multiple needs on a daily basis, as opposed to those who have a single disease and lots of resources. That's the only way we're actually going to allow technology to have the power that it can have in globally transforming health outcomes for people. And so really thinking about that intentionally and thinking about the trickle up is I think, a huge part of how we should start to focus on this stuff.
Yeah, one tiny example to illustrate that is the fact that I imagine most of the people in this room haven't had genetic tests or really regular genetic tests at the very least, other than if you had an advanced illness, which it was specifically relevant. But think about the fact that 25 to 30 years after the Human Genome Project, none of us are even using this technology in a country like this. So imagine the value of that in other settings. We're already kind of doing exactly what you said, which is often focusing on interventions that only a small group of people can afford and hoping those trickle down, instead of deciding to design from day one with everyone in mind.
Yeah, that's right.
I think you could even go further, which is a lot of the healthcare interventions we've seen that are aimed at the affluent of the affluent actually don't even improve their own health, right? If you think about over-screening for forms of cancer, if you think about how we overuse cardiac stents, I mean, it seems to me that when we go out of this public health perspective, sometimes no one benefits except providers. Before we open it up to everybody, can you just spend a minute talking to us, just kind of walking us through a delivery or two, right? Exactly. Because it's so fascinating. Rwanda, or if you want another place where you are, let us know. But just kind of take us through briefly what one of these deliveries looks like.
Yeah, I know that it's weird, and a lot of times it's easier to show rather than tell, because when we're just talking about it, people are like, nah, that has to be BS. But yeah, I mean, to give a really simple example, so what Zipline designs, obviously we're building technology, we build the aircraft and the avionics and the distribution centers, but ultimately the service we provide is really simple to doctors. In fact, all doctors that we serve are just placing orders via WhatsApp, which blows people's minds here. But this is, again, like when you actually have a medical system that's willing to work with you to find something that's like simple and that people actually like interacting with. That all the doctors we serve are super comfortable on WhatsApp, so they'll place an order, either emergency or routine. We get that order instantly, and we automatically confirm the order with them, saying thanks, the order is received, 3 units of A negative blood are on the way. And then it's a little like using Lyft. They get a time span. They're like, oh, they know it's coming in 15 minutes. And then about 1 minute before the vehicle delivers, they'll get a second text saying, please step outside. The zip is 1 minute away. Yeah. And then the doctor can basically just walk outside and we deliver into their mailbox, which is kind of like an imaginary rectangle on the ground. It's about 2 parking spaces. And that's everything they need to do to get like an instant delivery of any product they need to save a patient's life. It happens in an average of 15 to 20 minutes, and all the technology is happening on the back end. But the cool thing is, think about it from the perspective of the doctor. They're not dealing with any technology. Send a text message, get what you need to save a patient's life. And so that's really like, you were asking about, why don't people like technology more, or I was asking that, I guess. But I think the reason is that like it's not that interesting to go to a doctor and say, oh, do you want to use a drone for this? Like they don't care about drones. They just care about taking care of patients and having what they need to do so, to use their training effectively. And so our goal is to take all the technology and put it in the background, in a curtain, and your interface should be so simple and it should make your life better. And one of the things I often joke about is that when I go and visit hospitals, one of the things that's kind of mind-blowing is that doctors are like, it was a week of pure magic that like you had autonomous aircraft delivering and it seemed completely crazy. And then on day 8, it's like total entitlement. And it's completely normal. And it's like, what the hell, 16 minutes, you told me 15. So for us, that's kind of the sign that like the technology is actually working. It's that like, sometimes I walk to the sidewalk and I'm like, damn, I can't summon a vehicle to my GPS location in 2 minutes or less. When technology is working, you become entitled and you just rely on it. And that's like my hope for what some of this advanced technology can actually be to doctors over the long run. It's that it can just make your lives easier and let you focus on patients, and the technology should be in the background.
So last thing, oh, sorry, you want to
I would say the same for patients too, right? So, so you go to the App Store and there's like, 60,000 different health-related and wellness apps. You have to download the app. If you have hypertension, you have diabetes, and you have heart failure, it's 3 different apps, 3 different things you're supposed to do, none of which talks to each other. What we found is our patients they're not going to do that. But if you SMS them, if you send them a text message, like they'll respond. That's their kind of mode of communication. And to your point, all of the technologies on the back end, we don't need to get fancy. All the new devices and the wearables and the various kind of single point solution apps, they don't work unless they're integrated within a trusted kind of system and a workflow that is like truly responsive to a person's need and has like basically 0 friction when compared with their regular interactions with technology.
Yeah. What you want to be doing is solving the problems, right? Rather than doing high-tech stuff for the sake of it. So last thing before we open it up. So let's imagine it's 2018 right now, right? Let's imagine Spotlight Health 2040, right? Roughly 20 years from now. What are the aspects, I'm going to ask you to get out a crystal ball here, right? And the good thing is we won't invite all of us back in 2040, so if we're wrong, it's okay, right? What are the aspects of healthcare that will be most different in like a day-to-day way that in 2040 people will look back, like 20 and 30-year-olds will look back and say, that's crazy. It's like when they had to get up and walk across the room to change the channel on something called a television. What are your predictions?
I think we'll have far fewer, ideally no, hospitals. I think the idea that you get up and take a half day off of work, find childcare, get transportation, go to some place, sit around, wait for a while in order to get 10 minutes of healthcare will no longer exist. So the idea that I make an appointment to go see my primary care doctor and I have to travel to them, as opposed to have them come to me whenever I need it on demand, I think that'll go away. I think the idea, to your point about crossing the room to turn on the television, I had to cross town to go see my doctor. Why? I think that'll go away.
Because doctors will be
because care will be delivered in communities, both in like human to human as well as technology enabled. The idea that if I have a need between 8 and 5, I go here. If it's 5 to wherever, I go to urgent care. If it's in the middle of the night, I go to the emergency room. Same problem. That'll go away. And so I think healthcare will be on demand. It will be delivered to you, both by people as well as through technology-enabled human contact. And I particularly think the notion that our patients are subservient to our sort of physical edifices and our workflows as clinicians will go away.
Okay. Sorry.
Just,
Yep.
I mean, on that point, like I read the other day that I think 40 to 45% of all prescriptions in the US go unfilled. So I think there's really, I mean, a big thing that we miss is maybe sometimes, at least in the medical system in the US, the assumption is like, if we tell the patient to do something, they will do it,
Right.
Which never happens, and it basically doesn't happen to a mind-boggling extent. And I think all you have to understand is just, you know, that humans are lazy and they don't get the job done. So you gotta like.
That's why you feel drunk.
Yeah, exactly. No, I mean, I think of myself. It's the same way, right? Which is that like, I think a huge part of bridging this gap is making the care convenient. And I joke about it, but like, actually, the thing that I often think about is that, you know, everybody in this room, we have like the means to take a half day off work and get into a car that we own and drive to the hospital that is in our neighborhood. Like, that's not true for a large subset of people who live here in the United States.
Yeah.
You can't actually take a day off work, or you don't have a car to drive to the health facility. So, you know, as we can do what, you know, Toyin was describing and bring healthcare closer to people by providing diagnostics and even like a discussion with a doctor in your home over your smartphone, that will disproportionately help the people in the country who need it the most, because they don't have access today.
Jay.
Exactly.
Yeah, so this kind of goes back to the comments I made at the beginning. The first is distributed, which you just spoke about, and also coordinated. So the fact that you'll have automated reminders, the fact that things will be delivered directly to you, the fact that you'll have sensors that are seamlessly connected to the healthcare system such that things are being alerted and parties are becoming aware of information well before it might ultimately be necessary. The fact that it'll be more collective, so it'll be more community-based, it'll be more involving multiple care providers who might be able to provide insight into your problem. So, you know, not just going to a back surgeon, but also going to physical therapists, but also going to, you know, someone else who might have experience in alternative techniques like acupuncture or whatever it happens to be. And then in addition to that, the point about it being technology that gets out of the way, which I think that's a really powerful thing that Keller mentioned. And the way we move towards that is by using technology to actually automate a lot of the things that people find frustrating, like the coding and billing process, and hopefully over time actually getting to a place where we can actually use technologies like data analytics and AI to evaluate encounters on their actual clinical nuance. And if we could do that, we could actually get rid of, to a large extent, existing legacy electronic health record systems, as well as the traditional payment loop.
Great. Okay, you all. So we've got a couple microphones. I have 2 requests. We'll start here in the back. Tell us who you are, and please make your question a question.
I'm really not good at that, but first of all, I'd like to compliment.
Who are you?
I'm Chris Redlick. I'm chair of the finance committee at Stanford Health. I want to compliment you guys on your presentation. I believe each of you is spot on in what we need to do. Each element is an important piece. And I'd love to take you home because we need you desperately. But you're already doing very important work. My question is one of the barriers, I've been working on this for years through my existing position. And I find one of the barriers to getting this done are these closed systems that the hospitals and healthcare delivery systems have, like Epic.
You heard ya.
Death to Epic. How do you see, you know, is there an impetus out there to replace those kinds of systems? Are there people out there, young people, that want to change the system and do it in such a way that all the ideas that you have can be integrated in a distributed way?
Who wants to take that?
I can speak to it quickly. So in some ways, I actually think of that as like, you know, I think doctors might see it as like, it's this big frustrating system. As startups, we look at it as like, okay, so what's our approach here? Where can you get started? And this interesting idea that I heard Obama describe in one of the last interviews he gave was someone asked him about artificial intelligence and the regulatory implications of that and how should we be regulating it. And he said, look, we need to let 1,000 flowers bloom and then trim appropriately. And so from a startup perspective, the way we think about that is we're not starting with big systems like Epic. We have to go to the edges where we can find like small integrated systems that actually have the right incentives to save costs and provide better care to their patients. And a lot of times it only requires a few examples to to get started, right? A few champions who are empowered to make decisions to get started at least somewhere on the fringe, and then you can go from there.
Yeah, there's kind of a, oh, did you want to jump ahead?
Yeah, go ahead. While we get a microphone up here.
There's a couple kind of ways to attack that seemingly intractable problem, right? So one is to actually build solutions that work highly compatibly with the EHR to kind of automate things that are otherwise painful, like speech to text and natural language processing and other things that can speed up or ease that process, right? Remove de-anonymized data, things like that. The second is actually to create a process of essentially writing information to interfaces like EHRs, where you could imagine over time that large amounts of information are actually not ultimately dealt with through EHRs. They're dealt with through systems like WhatsApp or other kind of more easily accessible and usable systems where that information gets compiled down to the EMR, which is almost like the file system of a computer, but it doesn't actually, the app layer or where you're working on, the system is not that. But the third and the most radical one, which is the one I mentioned earlier, is if we could get away from a code-based billing world where in a fee-for-service world, the electronic health record is vital to the success and survival of a health system. If we get to a world where clinical encounters can actually be evaluated on their clinical nuance through a combination of physician review as well as AI, we can actually get to a world where the EHR becomes much less necessary.
Yeah, and if I could just add to that really quickly, I think to your last point, we have to start by asking what the use case is and letting health system transformation make those antiquated systems redundant. And so when we talk about value-based care and moving away from all of the functionality within our existing technology that's all transactional about billing and coding and documentation capture, when we move away from disease-focused healthcare to more holistic care, then all of the kind of the disease-based, problem list-based functionality becomes redundant. When we move towards fully integrated care teams, then the lack of functionality in these existing systems that allows us to communicate seamlessly through nurses to doctors to community health partners to community-based organization providers to housing and social services, we need that, and those systems don't support that. And so I really, going back to the idea that we are using technology as an enabler for our care delivery and not as a solution in itself, we've got to just rip and replace the system, and our technology needs will become very evident through that process. And in so doing, we will make redundant all of these tools that we hate.
Wow. Okay. Inspirational. My name is Sherry Barkin. I'm a pediatrician. I'm also a division chief of academic general pediatrics at Vanderbilt. And your point about over-treatment, I think we look at the fact that the U.S. really has over-medicalized civilization's diseases like anxiety, depression, fatigue, pain, and now patients have often given away their responsibility for their own health. They want a pill instead of behavior change, instead of partnering with their community. And this, I think, has led to excessive healthcare consumerism. So my question is, what is the treatment for healthcare excessive consumerism so we can better focus on where the healthcare system can be most effective?
Who wants to take that?
I mean, I'll start. I'm a little bit of a broken record about this. I think it's trust. I mean, I think that in order for people to change behavior, you have to provide a trusted source of information, and you have to do that within a system that is trustworthy, and you have to do that in a way that provides that allows the lack of a pill to not feel like a lack of something, but to feel like an additional set of tools, right? And so we have to move away from the idea that I'm going to solve your problem in 10 minutes, and the encounter that we have is sort of the end-all, be-all, and much more towards the notion of partnership long-term with our patients. That requires them to trust us. It requires us to understand them. It requires us to be accessible to them. And it requires us to really start to value outcomes, feeling better, as opposed to transactions, things I gave to you and did for you. And so I do think it's fundamental in that is the way that we engage with our patients, which is really hard to do in a fee-for-service world. It's really hard to do in a 10-minute visit. It's really hard to do when you have overvalued simply by the notion that a patient has to take time off work, come to you, sit and wait for you, that 10-minute interaction is suddenly so valued because otherwise they don't derive anything from the time that they spend with you. So I think there's a lot to do here about the way that we conceptualize and focus in healthcare on what matters, trust, right, relationship, understanding, a focus on outcomes versus what we do to people and for them.
I don't want
I
to
do
suggest
also
that-
think, oh, sorry.
I don't want to suggest the solution is easy, but there's been some interesting work where when you say to people, do you want the latest, most intensive, most high-tech treatment? Not surprisingly, they say yes. If you say to them, here are the benefits and the costs, I don't mean financial costs, I mean the side effects of the latest treatment, and here are the benefits and side effects of these other treatments,
Yeah.
fewer of them choose the most intensive, most expensive one because it's not always the best one for people, and people have different preferences in terms of what they want to do.
Yeah.
So quickly, so I want to make
Yeah,
sure we
just
get
a
to-
minor point, which is I think it's also a huge design issue. And I hope some of you got a chance to go to those seminars this week. But the big problem is we need to actually understand the psychology that human beings do want a pill, but can you reconstruct existing products to feel like they are a pill? So for example, Headspace is an interesting example with meditation, or Omada Health, the stuff they're doing with diabetes. You can almost make the product feel like a pill.
Yeah. Sir.
Dan Ovadia, orthopedic surgeon. First of all, let me compliment. It's a great panel, great moderator.
Thank you.
And let me attempt to try to integrate some of these things. I think at the heart of the whole problem is the way we bill, get reimbursed, and code. And I think this speaks to Rinaudo. This speaks to the huge disparity between what a specialist gets for care and what a primary care physician gets for care. So, Porter wrote about this. We don't really look at interactions or costs based on inputs, throughputs, and outputs. These numbers are pulled out and historically been pulled out of the air or out of where, and they don't really correlate with addressing population problems and public health problems. So.
Yeah, thank you. Okay, so I see two more right up here, and if you just pass that microphone forward. Do we have a second microphone to bring up here? Great. If we could just bring it around in the second row here.
Yeah.
Thank you.
First of all, great panel. John Madison, I've led a lot of the digital transformation at Kaiser Permanente. And the one thing I'd like to slightly reframe about the discussion is as follows. In healthcare, there's a lot of blaming the patient. So the very term non-compliance is about assigning blame to a patient, and oftentimes it results from not seeking to understand what the social aspects of healthcare are. So there's lots of the talks have been social determinants of health. I'd like to flip that into blaming the health record vendors and blaming the physicians for hating technology. Physicians hate bad technology. Health record vendors are trying to do the best they can with existing technology in a tightly regulated environment. And so I think what we have is solution sets that don't accommodate real human needs, not based on human-centered design and constrained by both available technology and the regulatory environment. So I would suggest that the biggest solutions to this hating the health record and hating technology are right in front of us, with two profound changes that are about to sweep the industry. The first is completely voice interaction-based technology, so that the keyboard interface to healthcare is going to go away. The second is having machine learning in the cloud, so that we can not only improve the quality of care, the quality of outcomes, the safety of care, but also the efficiency of the operations. And the last thing I just want to throw in is that it's easy to compare healthcare to other industries and why we're so far behind. The human condition is far more variable and far more difficult to model and manage, and I think the work that Jay's doing with the hypergraph design of healthcare knowledge is going to play a huge role in informing that machine learning through a voice interface. And it may be completely different vendors that are rip and replace, or it may be just layering on these two technologies that I think are going to completely revolutionize everything about the doctor experience. And the epidemic of physician burnout is really a consequence of all of these constraints, but I think we're on the cusp of a radical transformation within a year or two.
It reminds me of what you said, that the point isn't the technology, the point is solving problems.
Yeah.
Right? And if patients aren't complying, well, there's a problem somewhere before you get to the patient, right?
Yeah, I mean, exactly. I don't think I have anything to add.
Right here. Sometimes when I write about an economics topic like the Federal Reserve or something, someone will come up to me and say, I wasn't smart enough to understand your article, which they don't realize, but they're trying to be nice, but that means I completely failed, right? That means I totally failed, and that's reader non-compliance.
You're just too brilliant. Thank you for a great panel. Karen Brooks at TPG Capital. We're the largest private equity investor in healthcare worldwide. Keller, a couple of questions for you. I'd love to ask all of you, but in the interest of time. So Zipline is delivering blood and vaccines not only on demand, but affordably. So my first question is, how did you crack the code on the affordable part? Secondly, do you aspire to try this in the United States? And thirdly, what's next for you or Zipline or you as an entrepreneur?
Okay, yeah, I'll answer very quickly. So number one is on the affordability front. You know, the exciting thing about all of this new technology is that technology makes very powerful solutions available at decreasing cost. You know, the phone that you have in your pocket has gotten twice as good every year for 10 years, and it's the same price. And whereas in healthcare, we've seen costs just basically rise forever. And that's a sign that technology is not being utilized to actually make us more efficient at our jobs, which I guess goes to show that, like, if you're actually willing to go and try something radically new and radically different, and you have the buy-in from the healthcare system to do so, there are opportunities to reduce costs by orders of magnitude. And that's what we're doing. That's how it's possible for us to provide this seemingly very high-level advanced technology service at a price that's cost competitive with motorcycles. And the second question about coming to the US, it's no mystery to any of you that critical access hospitals in the US and rural places in the US are closing at a record rate. We have the highest rate of maternal mortality of any country in the developed world. And people who live in certain rural parts of the US, their life expectancy has actually declined in the last 15 years. Whereas the life expectancy of people who live in cities has risen by almost a year and a half in 2 years. So there's a big subset of people in this country who we are letting down. And access to healthcare is not just a challenge in the developing world, it's also a challenge here. And so we're super excited. We actually are working with the US government to begin doing commercial deliveries in North Carolina before the end of 2018. And our goal is to serve primary care clinics and rural hospitals to basically give them a portal. So they can reach their hand through the portal and instantly pull out any product they need and hand it to a patient without having to stock that product. So that's kind of what's next for us.
Please join me. We're out of time. Please join me in thanking this panel. And also, thanks to the Institute. Really wonderful group.